Can you hear me, Kevin, okay?
I can hear you.
Kevin, am I coming through okay as well?
Yes, Tim, I can hear you just fine.
Okay, great.
Yeah, great. I'm just going to go back to the meeting for now.
I can hear you, but I need to turn up my sound. Just trying to figure out how I do that.
Okay, sounds good.
I've got a big, let me just see here if I escape that. No. There, I should be able to get my. Kevin, can you speak again?
Yes, I'm here.
Yeah, great. I can hear you. Can you see me?
Your video is turned off currently.
Okay, that's good. And I'm just checking how I can, should I try to share my screen with you now?
You can if you like, but it should be pretty, yeah, go ahead if you wish, but it's pretty straightforward. I haven't had any problems in the past.
Yeah, I don't even see an option here to do that just yet. Oh yeah, share screen, okay. Okay, it says I can't do that yet, so we'll just wait on that.
I have to stop sharing my screen, so I can do that briefly. Here, let me stop sharing my screen briefly. Go ahead.
Okay.
Yep, there you are.
And I'm just trying to see how I can control it. Okay, that's great. So
Yeah.
up there. How are you doing today?
Doing very well. Yeah, it's morning for me. I'm on the West Coast. Tim's on Eastern time.
Yeah, thanks so much for joining us, Sherry. Really have enjoyed reading through your your abstract and look forward to hearing more today.
Yeah, I mean, I hope some of the people that were presenting in the day conference that you did, there were some that were related to this topic. So there'll be some of that crew there.
Okay, I just took back over the sharing so I can have this placeholder slide up. Welcome to those that are joining in so far. We're going to give it another about 5 minutes before we get going. So just hang tight and we'll be with you shortly. Welcome to all those who are waiting. We're going to give it just a few more minutes and then we'll get started about 2 minutes after the hour. Well, good morning, good afternoon, or good evening, depending on where you're located right now and where you're dialing in from. This is a follow-up to our LifeData Insights conference from earlier this month, which was our first annual go at this virtual conference. And these monthly symposiums are an opportunity for different folks in the community to be able to share their good work and to be able to get feedback from others and questions. We're going to be conducting these on the 4th Friday of each month at 12 noon, this same time. And please be sure to send any of your questions through the Q&A function in Zoom as we're going along here. We'll also look forward to having any of you who would like to be featured as a speaker at any upcoming symposium. Please do go to the connect.lifedatacorp.com website. And please do go to that page for the community and look for the form and fill out a form and send that in to be a speaker at one of the upcoming symposiums. The next one is going to be June 26th, and the registration for that is already live. Additionally, when you signed up for the symposium, if you weren't already an attendee of the conference, you were not signed up for the community portion of that website, and you can certainly go back and register for that and have access to the forum and an opportunity to connect with others online well, outside of the symposium. Thank you again for joining us. And today I'm going to introduce Tim Steenberg, who is another LifeData founder, and he will be introducing our featured speaker.
Thanks, Kevin. Want to again welcome all of you who are joining from all over. It's great to connect with all of you again. As we begin this symposium, we're really honored to have Dr. Sherry Stewart with us. And let me share just a little bit about her background and then make the introduction. So Dr. Sherry Stewart is a Tier 1 Canada Research Chair in Addictions and Mental Health and a professor in the departments of Psychiatry, Psychology and Neuroscience, and Community Health and Epidemiology at Dalhousie University. Dr. Stewart is a recently inducted Fellow of the Royal Society of Canada. She is respected internationally for her research on psychosocial and motivational factors that contribute to emotional and addictive disorders and their co-occurrence. And so we're really honored to have her. Dr. Stewart has received funding from various agencies to develop and evaluate novel interventions for those who struggle with emotional and addictive disorders. She's founded the Center for Addiction Research at Dalhousie. This is a virtual center fostering collaboration among faculty members conducting research on addictions. Dr. Stewart also serves on the CIHR-funded Canadian Research Initiative in Substance Misuse. Now, as I introduce her, I also want to mention her collaborators, Kayla Joyce, Kara Thompson, Philip Thibault, Kimberly Good, Tara Perot, and Elizabeth O'Leary. We're so grateful for their contributions to this project. Today, she will be presenting an EMA study looking at the relation between depressed mood and coping motives with cannabis use quantity across the menstrual cycle, specifically comparing cannabis users with and without premenstrual dysphoric disorder. So thank you so much, Dr. Stewart, for joining us. I'll remind our attendees that you can, again, share questions through the Q&A interface on Zoom that's located there at the bottom of your screen. And so, Dr. Stewart, we'll hand things over to you and then invite questions at the end of your presentation.
Fantastic. Thanks so much, Tim. I think I have to, in order to show myself, I have to have somebody open up the video.
You are all good for that.
Okay. When I hit it, start video, it's saying that the host has stopped it.
Oh, your video. I apologize. Let me see.
Problem?
Just a moment. You should be able to use it, and hold on just a moment. Okay, I think you should be okay now, Sherry.
There we go.
Apologize for that.
Yeah, no problem at all. So I wanted to thank both Kevin and Tim and LifeData in general for organizing this set of symposia. And I really enjoyed the conference. I attended the conference a few weeks back, and there were actually a couple of talks sort of in this area. So I'm not sure if those speakers are here today, but I did personally really enjoy that conference. So it's nice to see this continuing on a monthly basis. Now, I'm just going to make sure that I have shared my screen. Can you all see my screen now? Do you see my slides?
Not yet.
Okay, 1 second. I will get rid of this for a sec. Can you see them now?
Yep, we're all good. Perfect.
Great. Okay, so I'll get going. So I'm going to be sharing with you a particular study out of a series of studies we've been doing regarding the menstrual cycle in women and its relationship to various addictive behaviors. So we've published 2 studies in this area, one on alcohol and one on gambling behavior. And this more recent study was done as a master's thesis by one of my students. I'll be telling you about that at the end, Kayla Joyce. And this one in particular, we used ecological momentary assessment methodology to look at the relationship between variations in depressed mood, variations in addictive behavior motivations across the menstrual cycle, and how those relate to levels of consumption of cannabis across the menstrual cycle. And we compared 2 groups of women who meet a provisional diagnosis of premenstrual dysphoric disorder and those that don't. So this is part of a series of research projects that we've really been interested in these questions across addictive behaviors. So first of all, what about females and cannabis use? You might start off thinking with a little bit of a bias there that, well, isn't cannabis use more of a problem with men than with women? Why would you study it in women? And in fact, you're right if you had thought that use of cannabis is higher in men. Men have higher rates of cannabis use disorder. But there are a number of factors around women and cannabis use that are kind of unique and interesting, and that really justify our focus on women and cannabis use in this study. First of all, women compared to men have a higher susceptibility to having comorbid mood disorders along with cannabis use disorder. And so that might present some unique challenges in terms of treatment. There's also a phenomenon known as telescoping, where there's a shorter time between the onset of use and the development of problems in women than there is in men. And you see that across a few different addictive behaviors, and cannabis is one of those. There's also some recent evidence around gender convergence, that the gender gap that I told you about between men's use and women's use is narrowing, and that's as a function of more women using at heavier levels. So this is concerning, and it's concerning particularly in light of trends for legalization. So in Canada, we've legalized, and I know that's happening in a number of states in the US as well. And you know, around the world, there are trends towards legalization. So with increased accessibility, we do have to be concerned about these trends with women. So that's led some researchers to look at what are some unique aspects that might explain cannabis use in women. And the menstrual cycle is one of those unique female-specific factors. And I just wanted to kind of review the menstrual cycle with you all. There is no agreed upon standard way to break down the phases of the menstrual cycle, but if you look across studies, there is fair agreement that we have at least 5 phases that people talk about. So the menstrual phase starts with menstrual bleeding, that counts as day 1. So days 1 to 5 are considered the menstrual phase, moving into the follicular phase from days 6 to 12, then into the ovulatory phase where ovulation occurs from days 13 to 16, then the luteal phase, which is a phase of more variable length. And this lasts from day 17 to the onset of the premenstrual phase. So it can vary in length across women. And then the premenstrual phase is typically considered the 5 days before the onset of menstruation. And we do have very consistent findings around hormonal variability across the menstrual cycle. So here are 2 hormones that are commonly studied around the menstrual cycle, and one is estrogen, the other progesterone. There are others that vary cyclically across the menstrual cycle as well. Estrogen, as you can see, is low around menses and in the follicular phase, and rises just prior to ovulation and drops precipitously at ovulation. And then there's a second peak in the luteal phase, and it drops again at the menstrual phase. And you can see there's quite a different pattern with progesterone, where it's low until the time of ovulation, where it rises quite substantially, peaking in the luteal phase and precipitously dropping just prior to menstrual bleeding, so in the premenstrual phase. So these changes across the menstrual cycle do seem to be linked to changes to behavioral and affective changes. So what about mood across the menstrual cycle? What do we know? This has probably been the best studied, is mood changes across the menstrual cycle. So we know that the menstrual and premenstrual phases are associated with more depressed mood, with increases in depressed mood for women in general. And there's very drastic increases in those with a disorder named premenstrual dysphoric disorder. So they have very widely changing levels and increases in negative mood in the premenstrual phase that sometimes lasts into the menstrual phase. What about substance use across the menstrual cycle? So this has been studied less often than mood, but there is a substantial literature. We actually just completed a literature review on this very topic that's under review right now. And across alcohol, nicotine, caffeine, and cannabis, probably best studied in the case of nicotine and most well established that there are increases in nicotine consumption in the menstrual and premenstrual phase relative to other phases in women. There's some evidence similarly with alcohol, but it's less consistent, and really not as much evidence for cyclical variability in this pattern with caffeine. Cannabis has been less commonly studied in this respect, but in terms of what do we know, we do know that just talking about addictive behaviors in general, that motivations for addictive behaviors seem to vary across the menstrual cycle. And most often when we talk about motives or reasons for using substances, they've been conceptualized more as traits so that people vary. There's the individual differences in why people use particular substances, with coping motives seeming to be the riskiest of the motives in terms of their associations with both heavier levels of consumption and more problematic use. So coping meaning using to manage negative emotional states or using to manage stress. And that's true certainly in the area of cannabis use, that trait coping motives for cannabis use are associated with greater levels of cannabis use. And interestingly, there are some gender differences. So there seems to be a stronger link between trait coping motives and cannabis use in women than compared to men. More recently, people have started to conceptualize motives as states, as having some state-like properties, so that people's motivation for engaging in different addictive behaviors seems to vary across time and across situations. So that they do seem to have also these state-like properties. And that's led some researchers to start to investigate, well, do they vary in women across the menstrual cycle in a reliable way? And it does seem that both alcohol and nicotine use increase during the menstrual phase. So that's something that's been found consistently across the few studies that have been done. So I mentioned earlier that there haven't been too many studies on cannabis use across the menstrual cycle. What do we know from those studies that have been conducted? It's a really conflicted picture, to be honest. One study back in the 80s suggesting no change across the menstrual cycle. Another study showing in a subsample of women there were increases premenstrually and menstrually, but that was only in a subsample. But interestingly, that subsample also had the higher levels of premenstrual distress, so premenstrual negative mood increases. A pilot study that we did in our group, so that's the Hansel et al. 2019 study that was published in Cannabis, we showed that there were increases during the premenstrual phase relative to other phases of the menstrual cycle, just in women in general, and that those were associated with increases in stress levels at that same phase, self-reported stress levels at that same phase. But there are some limitations in the studies that have been done. First of all, as you can see, some of those studies were done back in the 80s before we had ecological momentary assessment. So when people were doing daily diary studies like the Griffin study in '85, people were mailing in surveys, and we can never be sure that they actually just fill them all out the day before, put them in the envelope and send them off to get their compensation, for example. So we really don't know, now that we have EMA and we have time-locked data, we can be a bit more confident about when people are completing their surveys across the menstrual cycle. Also, the second study by Milo et al., this one wasn't done out there in the real world. It was done in a laboratory, and it was women, engaging in a progressive ratio task to, pressing a bar to earn puffs of a marijuana cigarette. And so there could be a lot of criticisms about the ecological validity of that kind of methodology. Is it going to transfer to people's real lives out there in the real world? So EMA is a really good solution to see if those findings replicate outside of the lab. And then our study was really a very small pilot study, a small sample size, and we didn't look at either, although we did use reliable EMA technology, we didn't look either at mood changes. We only looked at stress. We didn't look at motives, and we also didn't look at any individual difference variables that, the data from Milo and colleagues is suggesting might be important, like premenstrual dysphoric disorder or symptoms of that disorder. So in this study, we wanted to test two sets of hypotheses. The first was drawn from the self-medication theory. So conscient self-medication theory posits that one of the reasons, an important reason that people use drugs is to manage negative emotional states, and that they learn to do so for substances' ability to soothe negative emotions. And so emerging from that, applying that to the menstrual cycle, it would suggest that there should be significant associations between daily depressed mood, daily coping motivated, coping motives for cannabis use, and greater cannabis use quantity, and that should be happening at two theoretical phases, the premenstrual and the menstrual phase, where we know those kind of increases happen for women. Secondly, we also wanted to look at moderation by an important individual difference. So looking back to Milo's study and finding, his findings that there was a relationship between premenstrual distress and increased working for cannabis in the lab, we wanted to see if that would really translate into our findings. So we thought that the first hypothesis, the self-medication hypothesis, would be moderated by premenstrual dysphoric disorder, by the presence of that diagnosis, so that females who have a premenstrual dysphoric disorder diagnosis would show stronger associations between depressed mood, coping motives, and cannabis use quantity during the premenstrual and menstrual phases compared to women who don't have premenstrual dysphoric disorder. So, we were really expecting to see this across women and more exaggerated in the PMDD group. So our participants were 69 normally cycling female cannabis users. We made the decision, actually we had 88 in our sample, and we used a very stringent criteria that women had to complete at least 70% of their daily diaries in order to be included in our analysis. So that resulted in 69 women out of the 88. So the demographics of that subsample that we used in our analyses was they were close to 30 years old on average. About 83% were Caucasian. We did ask them, we used the cannabis timeline follow back early on in the study, at the initiation of the study, to get a sense of how often they were using cannabis. And about 55% of them, so the majority of them, were daily users. And also the majority of them, 60%, met criteria for hazardous use or cannabis use disorder on the QDIT, so a validated self-report measure of cannabis use problems. Out of the 69, 19 met a provisional diagnosis of PMDD, and I'll talk about that in just a minute. So we had a relatively small sample of women with PMDD, but enough to be able to use the analytic techniques that I'm going to be speaking about today. So there were 5 different phases, or I'm going to call them sessions, that the women were involved in for the research. The first was the telephone screening. So we made sure that they were of reproductive age, that they had a normal length menstrual cycle, that they were normally cycling, so that that meant there was no interference with their normal menstrual cycle. They weren't taking oral contraceptives, they weren't pregnant, they weren't nursing, those kind of things. And if they were eligible, we scheduled them for sessions 2 and 4. And this is where they came into the lab and they gave us progesterone, they gave us salivary samples for us to test their progesterone levels. And that was used as a validity check about their self-reported menstrual cycle day. So we had 2 different sessions where they did that. One was scheduled to be at a theoretically low level of progesterone, so days 1 to 7 in the cycle, and the other was a high progesterone day, somewhere between days 18 to 24, just to show this on that figure that you saw earlier. So we selected days when we knew they would be theoretically at a low level of progesterone or where they would be at their peak of progesterone levels, just to get a good sense of where they actually were in their menstrual cycle relative to what they were saying on their self-reports. Now, in that first laboratory session, so we scheduled the first laboratory-based session to be the closest time of those 2 times in their menstrual cycle to the telephone screen. So that was random, really. And at that first session, they completed a variety of self-report questionnaires for the purposes of the talk today. The 2 that are relevant I mentioned earlier are the Cannabis Use Disorder Identification Test, the QDIT-R to assess problems with cannabis use, hazardous use, and cannabis use disorder, for example, and the Cannabis Timeline Follow Back to get a sense of how often they were using cannabis in their daily lives. And that was over the past 30 days. We also did the structured clinical interview for DSM-5 disorders, the mood disorders module, and they provided a saliva sample at that first laboratory session. So what is the structured clinical interview for DSM-5? I imagine many of you know. We use the mood disorder portion, so it's a structured interview to get at any disorders related to mood that the woman may have been suffering from. We used it primarily to identify those with PMDD, but just to also get a sense if they were suffering from other mood disorders that might explain our results. And this has a good reliability from other research. Now, in session 3, so after they finished that first lab-based session, then they would start their ecological momentary assessment. So they'd start at various points in the menstrual cycle across women in our study. And what's of importance for us, we had a couple of times per day that they filled out the measures, but the ones that are important for us today is the 10:30 a.m. survey. So at 10:30 a.m., they provided information about their cannabis use quantity the day before, their motives for using cannabis if they had used cannabis the day before, their mood on the current day, their mood and stress levels on the current day, and also they provided information about what day of the menstrual cycle it was for them. So just a little bit more information on each of those. So we gave a definition of a standardized joint equivalent so that they could tell us about how many standardized joints they had consumed the day before. So they provided that in an open-ended fashion. This is how they were queued. And that came from Zeser and colleagues of how to get fairly reliable data on cannabis use quantity. We also asked them if they had used cannabis on the day before. They were queued for 2 questions about their coping motives for use, their state coping motives for use. So yesterday I used cannabis because it helps me cope with negative mood, and they had a visual analog scale that they would slide along to tell us how applicable that was for them, as well as helping them deal with stress to help them relax or unwind. And as you can see, we had good internal consistency between those 2 daily monitoring questions. We also had a similar visual analog scale used for their mood assessment on that day at 10:30 a.m. So they told us how sad, how depressed, and how blue they were feeling on 3 different VASs. And again, we had really excellent internal consistency across those 3 mood measures. So they did this for 32 days to capture the full menstrual cycle. So women would have varied in their length of menstrual cycle. So we used a 32, the sort of longer length, to make sure we captured a full menstrual cycle for each participant. They also told us about their menstrual cycle day, and they were told that day 1 was the first day of menstrual bleeding, so they were to indicate the day from their last menstrual period. If they didn't know when their last menstrual period was, they were to indicate unknown until they reached the first day of menstrual bleeding. Then they would indicate day 1, and then the research assistant would go back and do a backward and forward count method to determine the day of the menstrual cycle for the rest of the cycle. On the second in-lab session, so if they had come in on the theoretically low level of progesterone for session 2, then they came in for the high progesterone level for their second in-lab visit, or vice versa. So it was always collected during the opposite days. We have an illustration there to just show you how we collected the saliva sample. So this was the passive Druel method. So they were taught how to do this and then provided their saliva samples. And these were analyzed using ELISA kits, so enzyme-linked immunosorbent assays, to determine progesterone concentrations. And this is a non-invasive and quite reliable method of validating self-report menstrual cycle day. And in terms of data preparation, what we had to do after we had the 32 days in for each woman was we had to lag the retrospective variables so that the cannabis use matched up with the earlier self-reported mood. So we did lagging for both the motives and for the cannabis use quantity so that they were reporting about the same day for the mood and the motives and the cannabis use. We also standardized a menstrual cycle day. Now, a lot of research does this, and some of our own research included, just collapses across days of a phase and gets a mean for each phase, and then that's what's analyzed. We wanted to use a technique where we were examining this continuously across all days of the menstrual cycle, which meant that we had to put women onto a common 28-day cycle. So we had women varying, they were all within normal range, but ranging from 26 to 32 days. So we had to do some condensing or some expanding of the data so that it would fit onto a 28-day cycle. And consistent with the literature, the variability is really at the luteal phase. So that's where we did the compressing or the expanding so that everybody got onto that 28-day cycle. We have published on that methodology for anybody who's interested in trying to replicate what we do or learning more about how we do that. That's in a 2018 publication, Joyce and Stewart. Now, our main analyses were done with kind of a novel technique. We've used it in one of our studies before. It's called time-varying effect models. This allows you, first of all, to look at intercept-only models. That's where you look at across the menstrual cycle, across the 28 days, what's the pattern in your data. And it's really just descriptive. So you're seeing where you're having your high points and your dips in your levels of cannabis use quantity or your coping motivated use across the menstrual cycle. There are no real statistics used here. You just are looking across the menstrual cycle for the patterns in the data. Where the statistics come in is in the time varying effects models. This is where you can, it's really similar in some ways, I think, to a mediation analysis over time. So you're looking at how does the changes in one variable over time impact another variable over time, and can you conclude that depressed mood is having an impact on cannabis use quantity at any particular days of the menstrual cycle, over that full length of a menstrual cycle. And you could similarly do that with for either depressed mood or for coping motives. What effect is it having on cannabis use quantity at each day, and then looking at that phasically across the menstrual cycle. We also use pair samples t-test to compare progesterone concentrations at that theoretically low time and theoretically high time to help validate their self-reports of the sample on their day of the menstrual cycle. So I'm going to start with the TVEM results, because they're the most interesting, and that's our hypothesis. So is depressed mood or is cannabis coping motives helping explain cannabis use increased cannabis use behavior, so increased quantity of use at particular points in the menstrual cycle. So if you just look, I think you guys can see my, I hope you can see my cursor, but you know, here is the menstrual phase, and here we're seeing the values go up above 0. And similarly, starting and later in the luteal phase and in the premenstrual phase, we're seeing values above 0. So at first glance, looks like the hypotheses are supported, but we have to look at the error bars, at the confidence intervals around our average. And these are not crossing 0 in any case. So in the full sample, we really aren't seeing evidence. It looks like there might be trends there, but there's really no evidence in the full sample of 69 for hypothesis 1 that coping motives are explaining increased cannabis use menstrually or premenstrually in the full sample. Same thing, cannabis use quantity is explained through increases in depressed affect, menstrually or premenstrually. Again, if you just look at the means, it looks like we have support for hypothesis 1, but our confidence intervals are not crossing 0. So this is not a reliable finding in our full sample. If I were to show you the figures for the non-PMDD group, so that's the 50 women who don't have a diagnosis of PMDD. I'm not going to show it to you. It's the same. So the trends look like they're there, but it's not significant overall. However, once we move into looking at the PMDD group, so this is getting into hypothesis 2, do we have a moderation effect? And here what we can see is this is the effect of coping motives in explaining cannabis use quantity across the menstrual cycle in the PMDD group only. And what you can see here is that during the menstrual phase, we do have our confidence intervals crossing 0, right? So we can see for a few days early in the menstrual phase and for a few days late in the premenstrual phase, we are getting a reliable effect here. Similarly, or partially consistently, what we're seeing with depressed affect driving increased cannabis use quantity in the PMDD group. So there's our 0 bar. And you can see at the menstrual phase, we're seeing some evidence of the effect crossing the 0 bar, so that depressed mood is explaining increased cannabis use quantity early in the menstrual phase for women in the PMDD group. The other thing I wanted to show you is some group comparisons of the intercept-only model. So this is just what's happening over time in cannabis use quantity. So I've got it separated by the PMDD group is in pink, and in blue is the no PMDD group. And we have our error bars around the confidence interval around the mean. The first thing I want to show you is, or point out in this figure, is that we have much more cyclical variability in the PMDD group than we do in the non-PMDD group, where it's fairly flat. Similar pattern, but fairly flat. The other thing is that there are some times across the menstrual cycle that we are seeing reliable, like the error bars, the confidence intervals are not overlapping, so that there is some evidence that women with PMDD are using at higher quantities across the menstrual cycle. When we just collapse across the entire menstrual cycle, we can see that that finding is coming out to be statistically significant. We see the same kind of pattern both with depressed mood across the menstrual cycle and with coping motives across the menstrual cycle. However, when we collapse across the menstrual cycle, we don't see that that change, that difference between the two groups being statistically significant. The other thing I wanted to show you was with some of these historical variables. So remember at that first in-lab assessment, everybody completed the cannabis timeline follow back so we could get an idea of the number of days that they're using cannabis. And I had pointed out earlier that the majority of the sample are daily users. Does that vary across the PMDD and non-PMDD group? And as you can see, it is. The majority of women in the PMDD group are daily users. And that's also true in the no PMDD group, but the difference is much stronger in the PMDD group in the proportion who are daily users as compared to non-daily users. We see a similar pattern of findings for the Q-DIT-R categories. So we put women into two categories. They were either hazardous users or cannabis use disordered by their Q-DIT scores, or they were non-problem users. And you can see the very large majority of women in the PMDD group are hazardous or more users. And that's also true in the no PMDD group, but it's much less, to a much lesser extent than what we see in the PMDD group. So that's a significant interaction there. I also wanted to, I spent a lot of time telling you about how we validate the self-reported menstrual cycle phase. So here's our data on progesterone concentrations. And as we would expect, theoretically, we are seeing higher concentrations on days 18 to 24 than on days 1 to 7. So self-reported days 18 to 24 are showing higher levels than self-reported days 1 to 7 in the total sample, helping validate that they're self-report, so the days are correct. So just to kind of go over the main results to summarize, so inconsistent with hypothesis 1, in the total sample, depressed mood and coping motives were not statistically significantly associated with heightened cannabis use quantity at the premenstrual or menstrual phase or any other phase of the menstrual cycle. But the PMDD results were quite interesting. Really, altogether, they do suggest that it's a useful clinical variable in relation to both use of cannabis and cannabis problems, as well as cannabis use across the menstrual cycle. So just in terms of relations to cannabis overall, we saw there was increased in the ecological momentary assessment across the 32 days. There was increased cannabis use, both across days and on average, across most days and on average. There was also greater risk for daily use and for having a problematic pattern of use, like resulting in negative consequences amongst the women with PMDD. What we also saw is consistent with hypothesis 2, that coping motives were associated with heightened cannabis use premenstrually and menstrually, and that depressed mood was associated with heightened cannabis use menstrually in this group, but not in the non-PMDD group or in the sample as a whole. So I wanted to mention a few of the strengths of this particular research. First of all, we selected women to have average menstrual cycle lengths, so there's not a lot of problem with their variable lengths. We could get them onto a standardization of 28 days pretty readily. We didn't have, none of our women had any interference with their normal menstrual cycle, including use of oral contraceptives or pregnancy and that kind of thing. The EMA allowed, relative to some of the studies done in the 80s, electronic timestamp surveys that were completed in relatively real time. We did have that retrospective assessment from the day before that I'll speak about as a limitation in just a minute, but we do know when they were completing the measures. And we have that standardization process so that we could look at cyclical variability and associations over a normal 28-day cycle. And we also did look, I'm really glad we thought to look at this individual difference, clinical individual difference variable of PMDD, because if we hadn't, we would have had really kind of, you know, a failed experiment or an experiment not establishing any role of the menstrual cycle in women's substance use. So I'm glad that we did that clinical interview. In terms of limitations, there is, of course, the limitation that menstrual cycle day was self-reported. We did have that validation, but it's still not perfect. And some people would suggest that you use that to throw out women who aren't showing for their own data a significant increase from across those two phases. We didn't quite go that far because we already had a limited sample size, but that's another way that some people manage that. Or you could get continuous assessment saliva samples across the full menstrual cycle. That's expensive. That's an expensive study to do those kind of assays across the full cycle, but that would be a way that could be done to get a better validity, and looking at more than just progesterone. You could have luteinizing hormone, for example, for ovulation. In terms of participants, the majority were daily cannabis users, and the majority had problems, were using in a hazardous manner or had a cannabis use disorder. And so that limits the generalizability. I think clinically, though, we've got a sample that is, where it's very clinically relevant. In terms of the EMA, we did make that decision to capture cannabis use to get the full day's assessment the next morning. So it's still possible, for example, that their mood that day could have influenced their retrospective memory for the day before. So we can't get around that with this methodology, unfortunately, but it is at least closer in time than the studies, where you're just looking at patterns, say, using the timeline follow back procedure for the last 30 days. You're getting it much closer in time. We didn't have an inter-rater reliability check with our diagnostic assessment. The person doing the diagnostic assessments was trained in the SCID, supervised by a clinical psychologist, so that's me. So I feel pretty confident about her diagnostic abilities. And we know that the SCID has a good inter-rater reliability, but we didn't do that check in this study. Also, we have a provisional diagnosis of PMDD. To get a true DSM-5 diagnosis, you have to have not just the structured interview results, but you have to monitor 2 consecutive cycles across the full menstrual cycle to get evidence that mood is changing in the way that it's expected to for PMDD. And it has to be 2 symptomatic menstrual cycles. So even with our 1 month, if we'd gone on for a 2nd month, that's not necessarily a symptomatic month for a woman. So this would have been too onerous for this particular study, but it is something that could be done in the future to get a better assessment. I'm sure not all of our 19 women would have met that more stringent criteria. In terms of clinical implications, our findings contribute to the understanding of how a growing body of literature on how ovarian hormones are influencing substance use in general and cannabis use in particular. And they really help us, they make some suggestions anyway on how we might be able to improve our preventative and therapeutic interventions for women that have cannabis use problems or who are at risk for cannabis use problems. So one example is that for women with PMDD, if they're trying to quit cannabis or cut down on their cannabis use, I would suggest that those cessation or reduction efforts would begin at phases other than the menstrual or premenstrual phase, so that they can so it's a little easier for them to stop and get some positive results under their belt before they hit the more difficult phase of the menstrual cycle for them. It also suggests that we would really want to work with that clientele in terms of developing more healthy ways of managing negative emotions, depressed mood in particular, at specific phases in the menstrual cycle, so that they don't have to rely on cannabis for that negative mood management. And I'm just going to stop here and open it up for questions. I do want to thank Kayla Joyce, who's my graduate student who did this project as her master's. And we just found out last week that she won the Governor General's Award for the best master's thesis at Dalhousie in the humanities and social sciences area. So I'm really proud of her for that. And all the co-authors were mentioned earlier. Kara Thompson helped us with the time-varying effects models. And Tara Perot and her graduate student Elizabeth O'Leary were helped with the progesterone assays. So we really appreciate their input. And our funders are all over on the left-hand side of the screen. Dalhousie Department of Psychiatry for funding the research, and Nova Scotia Health Research and SHRC for funding Kayla and her studies at Dalhousie. And now I'm going to open it up for questions.
All right. Well, thank you so much, Sherry, for that wonderful presentation. It does align with some of the work that we were able to hear about. I think Dr. Pang in particular, some
Yes.
of her work
Yeah, I thought so.
with premenstrual symptomology, and I think she was looking at cigarette
Cigarettes,
use,
yes.
as I recall. So
Yeah.
this is not my area, so sorry if I do stumble over a few of the details. We do have a few questions as well as some positive comments in general coming in on the Q&A. I do want to invite those who are in attendance to please submit questions if you have things you want to ask Dr. Stewart. One of the questions that's presented, on average, do you know if women with PMDD have lower progesterone levels at any point in the cycle?
That's a really good question. I think there has been some research on that, and I'm not sure how consistent that is, but that there are hormonal differences with women who have PMDD versus those that don't. And I'm sorry that like my area is more addictions than it is PMDD. I know there's a literature out there, and I wish I could answer that question better.
Sure. Okay, thank you. One of the things I guess I wanted to comment on, Sherry, was just the strengths of your approach, just in terms of taking an EMA data collection approach and recognizing, I think, increasingly we're trying to understand what's happening outside of the lab. We're trying to understand, when we want good data, of course we use the lab because we can kind of trust the data, but then we also have questions around ecological validity. And so I think your study really highlights some of the strengths of gathering data in the wild, as some would describe. One of the questions kind of bouncing around in my head involved participants' reports of their motives in kind of a retrospective way. And again, I'm a bit of a dabbler when it comes to the addictions. I used to do more work actually in gambling years ago, but yeah. Looking at that kind of retrospective on motives. And so one of the questions that I was wondering about is whether those accounts would align with mood symptoms. And so you're gathering mood data on the day, if I understood correctly,
yeah, actually,
and then you're gathering data retrospectively. And if you could maybe correlate the two, that would provide some.
We could actually do the TVEMs to answer that very question. So you could see, is depressed mood driving changes in coping motives across the menstrual cycle? So you could like flip it and have depressed mood be your predictor variable and coping motives be your outcome instead of cannabis quantity. We didn't do that. I think I remember that I wanted to do that early on, and we kind of got caught up in what Kayla was doing for her thesis, but that's really interesting. But I think, you also raise a good point that, like, what are they thinking about when they're doing a retrospective assessment on why did I use yesterday? And is that the same as what they would say if they were answering right in the moment? Like you can imagine that there'd be a fair correspondence between, like, if they counted up across the day, how many, joints did they have versus saying the next day, how many did they have? There should be fair correspondence there. But what's involved in a retrospective assessment of why I did what I did? And we also have data to assess that. And again, I haven't looked at it yet. So I mentioned that there was more than one assessment per day. And the first one was, a time contingent analysis that happened at 10:30 every day. But then their first cannabis use of the day, they were asked to then go in and do an assessment. And so they were asked about their mood before using and why they were using. So we would have that, like, is there correspondence between, at least for that first cannabis use of the day, does that correspond with what they say the next day about why they did what they did? So there's lots of rich data in this data set that we haven't fully, I guess, mined yet. A lot of really interesting questions that we could ask of this data set.
Absolutely. Yeah, in fact, we just had a question come in asking about some of that additional data. So thanks for describing that. One question, so we're, just to clarify, were participants throughout the day reporting each time were they instructed to report each time they used, or how did that work?
Only the first time.
Only the first time, okay.
Yeah, we thought about doing it every time. My experience in doing EMA data, I've kind of learned from my mistakes in the past. So one study, we had them reporting 6 times a day and we had lots of attrition. So
Sure.
yeah, so we're a little more careful now about like really making good use of the questions that we do ask them and trying to reduce participant burden, but get maximal information with minimal questions. So.
Yeah, no, thanks for sharing that that tidbit. I know for many of us, as we've kind of you know, launched into EMA work, we're learning some of those sometimes hard lessons,
Yeah.
and usually they come about through, as you said, attrition and non-response, which becomes even more difficult. Any other I guess methodological lessons or advice? Several on the call are likely using EMA or considering it. Any other lessons from this study or others that are kind of at the forefront of your mind when you're doing EMA work?
Yeah, I mean, again, like we tried to reduce participant burden. So we had like our motives questions. We just had those 2 questions. I really do wish that I had, like I didn't present it today, but we do have anxious mood, but we didn't get motives sort of broken down by anxiety versus depression. So that's something I would do differently in the future. Because it's not really that much more work for them to do another visual analog scale. I mean, you know, you don't want to overburden them with tons of them, but just, I guess, really thinking through theoretically what are the questions that you want answered and making sure that your assessments are going to capture, you know, your theory. Let's see what else. Yeah, I guess like in working with menstrual data, it's kind of amazing how many women don't know when their last, you know, when where they can't really self-report on their day of the menstrual cycle until the first day starts during, you know, when you're assessing. And so we've kind of debated in the lab, is it better to kind of just start then at day 1 of their, you know, first, like get them to hold on the questionnaires and start on the first day of menstrual bleeding, and then you can be more confident in what day you're dealing with. The problem there, though, is, you know, we've just done a study on cannabis reactivity, not across the menstrual cycle, but just is there reactivity? And there is. So as people complete these self-report measures over time, their behavior changes. Not a lot, but it does somewhat change. So I think, you know, if I were to do it again, I probably would just keep it the way it is, because you know, we've controlled for that. Everybody's starting at different days of the menstrual cycle, so we don't, you know, that will be averaged out across our participants. Yeah, probably.
Yeah, those are really, really helpful helpful tips. I'm mindful of the time, Sherry. It's flown. Thank you again for your presentation, and just want to congratulate you on this this work, and wish you much success as you continue to pursue this line of inquiry. So thanks again.
And thanks to the audience for attending, and I look forward to attending some more of these symposia in the coming months.
Well, thank you, and I guess we'll hand things back over to Kevin.
Okay, I'm jumping back in here. Just give me a second. Great. Well, I'm not finding my video, so I'll just go without video on this last portion. Again, thank you all for joining us. Really appreciate you being here today. We're looking forward to continuing to offer these symposia over the coming months and have more of you join in and have this opportunity to speak, whether this is completed work or whether you'd just like to share something that's in process or even something conceptual. We'd like to invite a lot of different types of speakers to come in and share, and then have the opportunity to even get feedback from your peers during this time. So again, the next one will be June 26th, the fourth Friday of each month at the same time. And thanks again for joining us. And please go to connect.lifedatacorp.com to be able to register for those events. And thanks again, Sherry. That was wonderful. It was really, really fun to listen to that. Yeah, I had all kinds of interesting thoughts from that go all sorts of different directions, which always happens when you have this type of a talk. So thank you so much.
Great. You guys everybody have a nice weekend.
Yep. Thank you all.
Bye-bye.